All right, guys, we have about a minute until we get started, but for everybody that's on the line, would you mind chatting in your name and organization? Just helps us keep a better track of who was able to log in and join us today. Also, if you are not currently speaking, if you wouldn't mind muting your lines, it just helps with background noise. That would be helpful. And we'll get going here in just a couple minutes. Looks like we have a few more logging in. I'm just going to give them one more minute here and then we'll get going. All right, we are going to get going. Welcome everybody to our first meeting for our HQuick NHA Delirium Learning Cohort. Thank you all for joining us today. For those of you that don't know me, my name is Dana Steiner. I work for the Nebraska Hospital Association on the CMS HQuick grant, which is a quality-focused grant that really focuses on decreasing harm within hospitals. We did a survey a while back, and one of the repeated themes was more information on delirium and how to care for a patient with delirium. So we started kind of doing some research and found that Nebraska has some really great resources on delirium work. And so we did an education on the 15th of February. And then from there, Chris was good enough to join us for 3 more educations, really focusing more on putting that information to work in your hospitals. I will let her introduce herself because I will not do her justice, but just some housekeeping items. We are recording this, so if you have people within your organization that are not able to join, they can listen to the recording. Please mute your lines if you're not talking, but we really are happy to accept questions throughout the presentation. Chris said she'd like it to be informal, so if you want to unmute and ask a question, that would be great. Otherwise, we'll be monitoring chat as well. Please put your name and organization in the chat currently so that we know everybody that was able to log on with us today. And then just as a quick follow-up, at the end of today, or at some point later today, I'm going to send out a short gap analysis because we are funded by CMS. They like us to have some outcome data. So it's basically just knowing where you're starting before we begin the cohort and then seeing if we made some progress as we bring the cohort to an end. I think that covers my end, and I'm going to pass the mic to Chris and let her start her presentation. Thank you.
Well, hello everyone. I'm happy to be here talking with you all today. My name's Chris Venovich. I am an adult gerontology clinical nurse specialist at Methodist Hospital in Omaha, Nebraska. I work as a clinical resource for two different units. One is a acute care for elders ACE unit. The other is a medical surgical unit that also specializes in behavioral health. Along with that, I have worked with the Age-Friendly Health Initiative and expanding age-friendly throughout our organization. And so we will go ahead and get started. I am going to take myself off of video while we go through this, just so I don't lose sound. Sometimes my computer doesn't allow me to have everything I want. So I'm just going to turn this off. And okay, so as we go forward, today our objectives, we're going to differentiate types of delirium, discuss importance of delirium screening tools, analyze different delirium screening tool options. We'll construct a PDSA model for delirium screening and implementation and determine population and frequency for delirium screening. And like Dana said, please, if you have a question, just interrupt me. I would really like this to be as informal as possible. I'd like to answer any questions that you possibly have. So this is part of the Age-Friendly Health System Initiative. Many of you were already familiar with Age-Friendly, and that might just be why your organization is participating in this cohort. But for those of you that are not familiar with Age-Friendly, it's a framework created by John A. Hartford Foundation and the Institute of Healthcare Improvement to provide age-friendly care to older adults through 4 evidence-based elements of high-quality care. So that's our medication, mentation, mobilities, and what matter most, our 4 M's. So today's discussion is in alignment with the best practice recommendations for mentation. On the screen, I do have a link to the guide to using 4 M's in the care of older adults, but if you reach out to Dana, I'm sure she can provide you quite a few more resources than I have in regards to that. So I'm just going to start off with a little bit about delirium. If you were on the webinar 2 weeks ago, you probably got a little bit of this information, but I just want to set a little bit of a foundation before we get to going on our plan. So delirium is a sudden, acute, and fluctuating change in cognition and attention. It's not a disease, but rather a group of symptoms. It's estimated that approximately 80% of ICU patients will experience delirium during their ICU stay. And it's the most common complication in hospitalized older adults, affecting more than 2.6 million older adults each year, with a healthcare expenditure of greater than $164 billion. So obviously a problem. Things I find important to know is that delirium accounts for approximately 30% of emergency room visits by older adults. It's experienced by nearly 50% of hospitalized older adults sometime throughout their hospital stay, and patients with dementia are 4 times more likely to develop delirium during their hospital stay, and this occurrence is referred to as delirium superimposed on dementia. So we have 3 different types of delirium. Our hyperactive delirium is most easily recognized type, may include restlessness, agitation, rapid mood changes, hallucinations, and refusal to cooperate with care. Hyperactive delirium rarely goes unnoticed, but not always identified as delirium. Sometimes we refer to it as altered mental status or acute alcohol withdrawal or metabolic encephalopathy or a wide variety of terms, but we want to get more comfortable using the term delirium. Then we have hypoactive delirium, may include inactivity or reduced motor activity, sluggishness, abnormal drowsiness, or seeming to be in a daze. So hypoactive delirium is associated with poorer prognosis and a higher mortality than other forms because it's often unrecognized by clinicians and caregivers, and reduced activity is often misattributed to low mood or fatigue. And then the third one is our mixed delirium, which includes both hyper and hypoactive signs and symptoms. The person may quickly switch back and forth from hyper to hypoactive states. This is the most challenging to diagnose due to the fluctuation. Clinicians may attribute the hypoactive delirium portion of this as the patient just requiring more sleep from being so active in their hyperactive state. So delirium, patients are admitted with delirium. Sometimes they develop delirium during their stay. When we're looking at hospital-acquired delirium, our most common symptoms are confusion, disorientation, difficulty maintaining focus, difficulty thinking clearly, sometimes hallucinations, sometimes aggressive behaviors, and sometimes just lethargy. The symptoms, they usually occur within the first 5 days of the hospital stay, but they really can occur at any time during the hospital stay. And as we're seeing throughout all of our organizations, hospital length of stay is significantly longer than it was in the past. This COVID pandemic has worsened our length of stay data as well as our delirium. But delirium symptoms, they may fluctuate and they might be worse at night. We often refer to that as sundowning. And important to know that delirium is usually temporary and resolves when the underlying cause is treated. However, if it's unrecognized and untreated, it can be fatal. So we'll just take a quick moment to differentiate delirium and dementia, because these two are the most common causes of cognitive impairment and sometimes difficult to distinguish. And mistaking delirium for dementia in older adults is a common clinical error that we really want to avoid. To help differentiate this, I like to look at it in terms of cooking equipment. So we compare the delirium to the frying pan and dementia to the crock pot. And delirium's like a frying pan because it occurs abruptly. It can really be cooked quickly, and the symptoms can fluctuate throughout the day. Whereas dementia, it's a crock pot because it's slow. It can last days to months. It develops over time, kind of like the crock pot takes a whole day to cook the food instead of like the frying pan that'll cook it so quickly. Delirium requires immediate medical attention, where dementia, it requires medical attention, just much less urgent. And dementia is typically caused by anatomic changes in the brain that are rarely reversible. Delirium, it affects mainly attention, sometimes consciousness, and is often accompanied by impaired thinking and hallucinations, whereas dementia, it's a decline of memory and other thinking skills. Hallucinations may be present in late stages of dementia, but again, different. So why is screening for delirium so important? Well, research shows that delirium is missed by clinicians in up to 70% of delirious patients. Only a third of providers and nurses accurately identify delirium. And our delirium screening tools, they're standardized assessments that when completed on admission to the hospital, routinely throughout the hospital stay, they provide a baseline for clinicians to identify decline in patient cognition. Delirium screening tools with good inter-rater reliability can clearly identify changes in the patient condition that can be recognized over time and between different clinicians, nurses, and providers. And once we recognize it, interventions and treatment can be initiated. So screening drives data and data drives practice. The literature tells us how significant the problem of delirium is. However, without our own organization's internal data, it's hard to perceptualize how great of a problem you truly have. It's even harder to articulate the problem to stakeholders, particularly when time and money need to be allocated for programming geared towards delirium prevention and treatment. So delirium screening is the first step. Screening goes beyond just identifying patients with delirium, but also allows us to capture the full extent of the problem within the organization. This is another good selling point for screening. If you don't have the data, how else can you measure improvement? So we must fully understand the problem in order to implement solutions and determine if those solutions are successful. So outcome measures could include prevalence, incidence, hospital length of stay, or mortality. But we will dive more into data collection and analysis in one of our next sessions. So let's start with a PDSA for our implementation plan. I like this process improvement model because it's simple and we can keep reusing it. So we'll start by defining our problem, which is delirium is underrecognized and underdiagnosed, and delirium increases hospital length of stay and our mortality risk. So our first step is to assemble our team and determine who your key stakeholders are, and if you have support to move forward with the process. And then we want to determine who the target population is, select a tool that meets the needs of this population, and then determine the frequency of the assessment. So when we're looking at who should be screened, that's really up to you and your organization. But will you screen all adults? Are you going to screen just older adults, patients in the ICU, patients in the emergency department, or patients in all areas? You'll want to know these answers before selecting your screening tool or screening tools. Some delirium screening tools are better suited for certain populations or may not be validated in all areas. As coming from my organization, we started with screening patients in the ICU using one tool, and then we screen the rest of our population using a separate tool. And right now we only screen adults age 65 and older, but we recognize that we're not capturing delirium in the younger populations. So moving forward with my organization, we will eventually expand to all adults rather than just older adults. Because like I mentioned earlier, we're missing alcohol-induced delirium, metabolic encephalopathy, delirium associated with hypercarbia or hypoxia, items like that. But you don't have to start with screening everyone. You can start small and expand. It's really up to you. So for tool selection, decide on the tool that best fits your team's culture. Analyze the components of the different tools to determine which one best fits your needs. Decisions can be based on amount of time it takes to complete the tool. Time is a very valuable thing. So if a tool takes a significant amount of time, it might not meet your needs. Look at training. Does the tool require specific training? Is it easy to learn? Is it easy to interpret, administer, and score? And then look at the versatility of the tool and how it works with different patient populations. What population is it best suited for? Does it have the ability to recognize hypo and hyperactive delirium? Does it allow scoring of patients who are too drowsy or too agitated? And then one item that I find really important is the compatibility with your electronic health record. Generally, you will have improved compliance with delirium screening if you have the tool built in your EHR. However, if you don't have that capability, paper screening is better than no screening at all. So I would push for screening no matter how you do it. But I will tell you, if you are able to build it in your EHR, it's much easier to pull data rather than having to manually enter it from paper. I would encourage you to reach out to your IT personnel to see if a tool is already built in your system. I know in the big systems like Epic and Cerner, there are several tools that are already built in there. For the smaller systems, there could be just a wide array of different tools, but reach out and find out what they have. Whatever you decide on, it is critical to use the tool only as instructed and to provide ongoing training to make sure that the tool is being used correctly. And for more guidance on screening and tool selection, I encourage you all to check out the Try This series, Assessment Tools for Best Practices of Care for Older Adults. This resource was developed by the Hartford Institute for Geriatric Nursing. It's a wonderful resource. I do have a link on the screen, and I believe after this, we can share the slide deck if that is helpful to you, but I really like to try this series. You can check it out for a lot of different reasons beyond just delirium. So our most common features in delirium are the top three I have listed on the screen: the inattention, disorganized thinking, and altered consciousness. The screening tool you select should include those features. Inattention is the hallmark feature of delirium. Individuals with inattention have difficulty focusing on the task at hand, maintaining conversation or shifting of attention. Disorganized thought, the patient's speech is incoherent. There could be rambling or lack logical presentation of ideas. With altered consciousness, this can range anywhere from agitation to lethargy. So commonly associated with delirium is the psychomotor agitation, psychomotor retardation, paranoid delusion, sleep-wake cycle disruptions, and emotional lability. Not all tools will recognize all of those features. Some of them will. I think it's a true benefit if they do. When you're looking at psychomotor agitation, this is recognizing patients that have movements that serve no purpose, like pacing, fidgeting, rapid talking, where the psychomotor retardation is slow thinking or slow to decreased body movements. How the verbiage is within the tool or presented within the tool may impact how your staff interpret the questions and may interpret how they ask the questions or how or their interpretation of the responses they receive to them. So I'm going to go through a few different tools, save you a little legwork on research. I'll start off by saying I'm just presenting a few different tools. There are many, many more other than what I'll be presenting. And the thing you have to know about tools is that there will be something that you love about every tool. There'll be something that you hate about every tool. You just have to pick which one is going to be best with your organization. So the one on the screen here is the confusion assessment method, the CAM. It continues to be the most widely used delirium tool worldwide. It provides an algorithm based on 4 core features of delirium, which is acute onset, fluctuating course of symptoms, inattention, and either disorganized thinking or altered level of consciousness. So if you can see on the screen, you can see those 3 features. To have a positive screen, the patient has to be positive in feature 1 and feature 2 and feature 3 or 4. The sensitivity is 94%, specificity is 85%. With this tool, there is a large operator variability. It does require knowledge of the patient's baseline, requires trained lay rater or a clinician. There is no licensing fee. And the CAM, being around as long as it has been adapted for use in the ICU, ED, nursing homes, palliative care. So it really is universal with little modifications in each of those areas. So this next one up here is the 3-minute diagnostic interview for the CAM or the 3D CAM. So this is a longer screening tool. It states it takes 3 minutes to do, but it's a 20-item screen. So there will be 20 items to document against. Data is captured from patient interview and observation of speech and behavior. The sensitivity and specificity are much higher than that of the regular CAM. It has a high inter-rater reliability. It does require training. This one is specifically validated for medical floors. No licensing fees for nonprofit or educational use. I did put a link to this one on the screen. You can get it from the Hospital Elder Life program. They do have free uploads there. And then I'm going to skip to this, the ultra brief confusion assessment method. This is not one that I use, but I think it's pretty cool, actually. The UB2, it's derived from the 3D CAM. It's quick, simple, requires little training, takes less than a minute to complete because it's really just 2 items. You're asking the patient the day of the week, and then you ask them to explain the months of the year backwards, or tell you the months of the year backwards. The sensitivity is good. Specificity isn't great, so it definitely identifies those who do have delirium, but it doesn't necessarily identify those who don't. So that's the downfall of it, but it is quick. It can be used on any population that can converse. I did put quite a few resources on this page because I thought they were kind of fun. The first resource is an education video. So this is just a quick 3-minute video that is like a caricature. And it would be really great for training. There's also a pocket card that is free for downloading for staff training as well. There's some literature, and the last link on there is some literature about an app-directed protocol. So with that study, for the app-directed protocol, it was done with nurses, nursing assistants, and physicians assessing the UB2. The app provides adaptive, interactive testing facilitated by use of an iPad. So all patients that participated with this research were screened utilizing the UB2, and if it was positive, then they would be screened using the 3D cam. And if the features in the UB2 were positive, then they weren't reassessed in the 3D cam in order to further shorten the protocol. The app retrieves information from previous days' assessment and assesses for acute changes. So with this, they call it the UB cam, with a combination of the UB2 and the 3D cam. And when you do that, you do have a higher sensitivity and specificity, and then you're not screening everybody with a more lengthy assessment tool. And so then here's just a quick view of the CAM ICU. CAM ICU, it's a 2-minute assessment. Sensitivity is 80%, specificity is 96%. There's poor validation outside of the ICU, but great validation within the ICU. It requires a knowledge of the patient's baseline, and there's no licensing fee. And then here's the 4A's test, or the 4AT. This is quick, 4-item. I believe it takes less than 2 minutes to perform. Looks at alertness, orientation, attention, and acute changes or a fluctuating course. Your sensitivity is 90%, specificity is 84%. This has been studied on all populations. There's no training required. And you're not required to have permissions, forms, or registration for download. And this includes utilizing it in your EHR. So I put a link to the 4AT website, because again, free to download whatever you'd like. Scoring can be a little bit confusing with interpretation of the score. Anyway, a score of 4 or above is considered possible delirium and or cognitive impairment. So score of 1 to 3 is possible cognitive impairment, and a score of 0 is stating that delirium and severe cognitive impairment are unlikely. So I think the scoring is kind of hazy, but with the right education, this could be a really great tool. And then here's the nurse delirium screening checklist, or the NuDesk. NuDesk is a 5-item screening tool. It takes 1 to 2 minutes to complete. Sensitivity is 86%, specificity is 87%. It does identify hypoactive delirium, which I really like. It doesn't require knowledge of the patient's baseline. It's suited for all populations. Requires trained lay rater or clinician. There's no licensing fee on this one. This is a good tool for nurses to administer. The language within the tool is user-friendly and utilizes specific examples of behaviors, so that I like. When you're looking at this one, our 5 features are disorientation, inappropriate behavior, inappropriate communication, illusions, hallucinations, and then psychomotor retardation. And then the last one that I'll share is the Nealon-Champagne Confusion Scale, or the NEACHM. This is a good tool as well. It is 9 items that are divided into 3 subscales. The downfall of this is that it does take 8 to 10 minutes to complete. It requires training. There is no licensing fee, and then you can see the sensitivity of 87% and the specificity of 95%. So then if we're looking at screening frequency, at a minimum, when you start delirium screening, you need to screen at least once a day. But our best practice recommendations state that screening should occur on admission to the hospital, every shift, and with any changes in the patient condition. If the patient's in the ICU, they really should be screened every 4 hours because their condition so frequently changes. or has the ability to change. So if we go back to our PDSA model, we just reviewed the plan, and now it's time to discuss implementation of the plan, or the do phase, if you will, and how we'll study it. I recommend trialing a small test of change first, maybe trial 1 or 2 units or areas first, or maybe in one population before expanding to the next. After trialing, collect feedback from staff, review any problems or unexpected outcomes. You can start analyzing the data, then start asking questions like, is the tool capturing delirium the way you thought it would? How's the inter-rater reliability between staff? Are they scoring it the same? Do staff understand how to use the tool? Do they need more or different education than what was originally provided? And the trial allows you to work out the kinks before full implementation or your next PDSA cycle. So once you feel you have appropriately worked out the kinks, then re-go through your PDSA cycle and expand it to all populations or the extent of populations that you'd like to. So delirium screen is positive. Now what? When we implement a screening tool, staff will want to know the purpose of the tool and what the next steps are. We can't just implement a tool with no interventions. So our interventions that you'll want to consider are developing a delirium care plan or a delirium order set. These could include non-pharmacological interventions, pharmacy consults for medication review, notification of positive screens to providers. Staff should include delirium screening in their shift-to-shift report and closely monitor for changes in patient status. So delirium has an underlying cause and is preventable and treatable in most cases. So care teams need to look at interventions that will remove or treat underlying causes of delirium, restore or maintain function and mobility, and prevent delirium complications. So the complications most frequently associated with it are like pressure injuries, falls, decreased function, muscle wasting, or permanent cognitive deficits. So I like this slide right here. I took it from the article by Rick et al. It's delirium in hospitalized older adults from the Journal of Hospital Practice. So here it clearly delineates delirium prevention and delirium management, because sometimes those two are very similar. In delirium prevention, we're implementing a multi-component team-based non-pharmacological interventions, usually multiple interventions. In management, we're going to evaluate and treat underlying medical precipitants, but also we are still going to use the same multi-component non-pharmacological interventions. That is always our first line treatment, as well as non-pharmacological strategies. And our second line is use of medications. So rarely are medications effective in treating or preventing delirium. And then only in the most severe cases should medications be utilized. And if we're going to utilize them, that's antipsychotics, the lowest effective dose for the shortest duration needed with a tapering plan in place. So then on this side, I have the acronym MIND spaces. So this is from the ANA from 2016. I really like it because MIND spaces is our acronym for our predisposing and our precipitating risk factors, something that we should be educating our clinicians and caregivers on routinely. So with the M, we're looking at medications, metabolic disturbances, mobility. I is infection, advanced illness. N is our number of comorbidities. And then D, we're looking at dehydration and disorders, including substance and alcohol use disorders. For spaces, our S is surgery or invasive procedures requiring sedation. P is pain, generally uncontrolled pain. A, age, our older adults over the age of 75 are at the greatest risk. Then we have appetite and poor nutrition. C is cognitive impairment, which is our dementia, so delirium superimposed dementia, and constipation. I see so much delirium from patients that are constipated. E is emotional or mental illness like depression, and S is our sleep-wake cycle interruptions. So here, next steps. So we've got a little homework before we next meet. I would recommend, if you don't have a team, start thinking of ideas of who is going to be in your team, develop your team, determine who your target population is, who you're wanting to screen, what areas you're wanting to screen, and start thinking about a tool. Get that in mind. Because when we meet again for cohort 2, we're going to look at staff education, how we can educate, some education features. We'll look at prevention interventions, treatment, and how to put together a plan of care. And I do have a list of additional resources here. I think these are great. I really encourage you to check them out. The American Geriatric Society, their co-care help, they have a list of delirium tools, delirium interventions. It's extremely helpful. idelirium.org is wonderful. NIDIS, the Network for Investigation of Delirium, Unifying Scientists. I have a link on here. This website has all the delirium tools listed, their information, their sensitivity, their specificity. So you can go beyond the list I have and start comparing and contrasting. Then we have the age-friendly health systems, and then recommended reads here. Dr. Inoue is just world-renowned for delirium research, so anything that she writes is worth reading. But 2020, she wrote The Delirium in Older Patients, and then the next one is Delirium in Hospitalized Older Adults that I referred to earlier. But I will back up here, and please, if you have any questions, go ahead and ask. I'd love to help.
This is Amber. I have a question. Would you mind sharing who's on your delirium team, or when these hospitals are creating their team or thinking about who should join, just what different departments are involved in, and how do you get that buy-in?
Okay. So ours was a little bit unique. But when we started delirium screening, we had a director or an executive involved, somebody that was going to, promote and help us move forward our initiative. We had an advanced practice nurse that was really doing the research behind the tools to kind of help us determine what tool we wanted to utilize. We had two different unit managers, because depending upon the size of your organization, you don't want to select a tool that is going to work with just one area. You want to expand your population. So it was good to have more than one manager. We had an educator on there as well to kind of help bring forth education, how we're going to push this out. And we did include a staff nurse. So now who you have on your team may vary, but that was very useful for us. And then as we moved forward, we trialed on a unit that was already screening with a different tool, because when we went to house-wide screening, we actually switched tools. So we had the bedside staff help in determining what tool we ultimately went with.
Awesome. Thanks for sharing. Does anyone else have any questions for Chris as you start this project?
Hey, Chris, this is Dana, and that was all awesome. I guess my question would be, as far as screening goes, do you often see people use a screening tool in the ED that is different than what they use on a unit, or do they usually have consistency across the board?
That really varies. So in my organization, the emergency department is looking at starting to screen. So they are looking at screening with what the rest of the organization is using. So for us, we do utilize the new desk. That doesn't mean that everybody should use the new desk, but that's what we utilize. So our ED is looking at starting with a new desk, because it would be really nice to have one set tool that we can compare and contrast as the patient moves throughout. But I have seen some really good literature on the CAM tool that's specific for the emergency department. So if you're utilizing CAM throughout your organization, I would definitely go with the ED CAM.
Great, thank you.
Does anyone else have any questions? I think I have a lot more, but I will wait until the next session because I think you might answer it for the next one. All right. Well, I think that was a lot of great information, Chris. Thanks for sharing today. The session is recorded, like Dana said earlier. So if you have a member on your team that wasn't able to join, you'll be able to find that on our NHA website. And also we are going to send out that initial gap analysis here this afternoon. So if you could work on that with your team, and as you build your team, we look forward to hearing what your plan is and using that PDSA cycle. So anything else, Chris, that you want to add before we close it out?
No, that's all I can think of for now.
Awesome. Well, thank you all for joining, and thanks, Chris, for sharing your expertise with us. But we'll give you back 19 minutes of your day, and have a good week.
Here we have